with these devices is that it can do some very negative things to patients' hemodynamics. Okay? So this is just a cartoon of this. So the blood is taken out of the venous circulation, it's taken to a membrane oxygenator and a pump, and then it's returned back to the arterial circulation. When we do this, what will happen to preload? What will happen to afterload? What will happen to these conditions in this patient on an ECMO circuit? Does anybody have any sense of what will actually happen? Yeah, that's the main thing that happens. So in a patient who needs their heart to rest, a patient who does not have enough oxygen getting their heart muscle, we're creating a condition where we increase afterload. If we increase afterload, the heart needs more oxygen and it's not able to rest. So we actually can make the heart even sicker in a patient who's on ECMO. Okay? Because we've actually made the loading condition worse for that patient. And also can increase the likelihood of the patient developing pulmonary edema. Does anybody know why they would develop pulmonary edema on ECMO? Why would their lungs fill with fluid if they're on ECMO? Exactly, exactly. So the heart's already weak. The heart's been damaged by a heart attack, and now we increase afterload. The blood can't leave this room. If the blood can't leave this room, some of it will actually start to go this way. And if it goes this way, they'll actually develop pulmonary edema. So in some of these cases, what we do, we actually put the impellant in also, so that the blood can be pulled out of this room that otherwise would have been stuck. So we actually have an ECMO and an impellant at the same time. And these patients, I'll show you on here. So if we start out with a normal curve, which is this black line, if you develop shock, it's going to be this red square. So in the red square, the left ventricular end diastolic pressure went up, and the inotropy, this line went down, so the effective stroke volume went down. Okay. And then if we put in an ECMO circuit on a patient like this, we actually will make their afterload go up even higher, and actually will make their preload go up a little bit too, and their stroke volume stays very low. And then if you add an impella in on top, you can actually kind of sort of meet in the middle. And so this is actually an unfortunate situation for this patient. This is a patient that's likely to end up needing a heart transplant at some point. But these are sort of techniques that we use to help to stabilize other organ function while we can come up with a better plan for these patients. But it's all based on preload, afterload, and chronotropy or inotropy. So we still have 8-10 minutes to go. You want to keep going? Or do you have any questions or comments on this stuff? Because that was a lot of information I went through. Yeah.
What is your experience and how long do you keep this patient on ECMO and only on ECMO? For how long?
It honestly depends on their presentation. Okay. So a patient who maybe was at home and ignoring their symptoms. Okay, they had the heart attack on Friday, and they think, okay, I'm a little bit better, and they stay at home. And then Saturday they're okay, but on Sunday they're very, very sick. And then on Monday they come to the hospital. That patient is already going to have some end organ failure, some kidney failure, maybe some liver failure. They are going to have a much worse course in the hospital, and their likelihood of needing support long term is quite high. Whereas a younger patient, let's say you have a 45-year-old man who had his first heart attack and immediately contacts emergency and comes into the hospital and has treatment. Now that patient likely will have a very short course of support and do quite well. And those patients even if they need all of this advanced support, oftentimes they can be very quickly decannulated within 12 to 48 hours, very, very quickly. So it honestly depends on the patient's underlying health and the overall presenting physiology. That's really what impacts all of this. Yeah? You guys are completely comfortable with all of this stuff. Nothing that you want me to repeat or go over again? So you can cure valve disease now and treat acute coronary syndrome?